The broadcast is now starting. All attendees are in listen-only mode.
Well, good afternoon, everyone. My name is Gustavo Friederichsen. I'm the Chief Executive Officer of the LA County Medical Association. Welcome to this incredible webinar that we're having today. It's powered by PC Med Ground Rounds Live. It's hosted by Mocingbird, a partner of LACMA's, and Orderly Health. I want to welcome all of you to this fantastic conversation titled, If It's Broken, Fix It, Physicians Healing Healthcare, and how career opportunities with a medical degree are available to you. You'll receive a 1 AMA PRA Category 1 credit, which is wonderful news for all of you to take advantage of. And again, we're going to be talking about really how being an entrepreneur in this industry can change the industry, improve the industry, and ultimately improve patient care, patient outcomes, and patient experience. A little bit of an overview, and I also want to give great thanks to Stacy and Katie from the Mockingbird team for their technical support and their help and their assistance. If I missed something in the chat, because as all of you might know, you can post something in the chat when we get into the Q&A section, when we get the tail end of this discussion. Keep in mind, we'll spend about 30-35 minutes having conversation. The panelists talking about different topics that hopefully those of you who are listening will derive great value from the conversation. We want this to be somewhat interactive. So I'll have Q&A at the end of the conversation, and you can post your questions in the chat as well. So a little bit of an overview. As you can probably see from the website or the materials that you received, the best medicine to solve burnout is sometimes self-administered. And this session is going to address the multitude of ways you as clinicians can help solve your problems and the health industry's problems. The participants will see how their peers manage to create companies that streamline dated, inefficient systems and procedures. Learners like those on the call will understand how they can better own their data, manage their ongoing compliance with relevant continuing education, provide in-home hospital care. So I cannot wait to hear Christine talk about how the pandemic completely changed that entire dynamic, and how getting access to care. And Navin's going to talk about that, or Navin's going to talk about that, excuse me. There are alternate ways to use medical degrees, and that's what we're going to talk about today, because you have physicians on the panel today to talk about how they're turning their degrees into leading innovative companies. So again, if it's broken, fix it. Physicians Healing Healthcare, career opportunities with a medical degree. Welcome everyone to the call today. And I'm going to let the panelists introduce themselves, but before they do that, or after they do that, you know, we received several questions from physicians around the country. And the number one question seems to be, what was your lightning strike moment that led you to even to become not just a clinician, but a founder, a leader, an innovator? You were trained to be a physician, and now you're leading a company in a post-pandemic environment. So I'm going to start off with you, Kit. Introduce yourself, and then go right to that lightning strike moment, if you don't mind, and then we'll go from there.
Yeah, thanks, Gustavo.
Sure.
So my name is Kit Kieling. I'm a pediatrician by training. I spent the first decade of my career in academic medicine. I was the third-year pediatric clerkship director at the Uniformed Services University, the military's medical school in Washington, D.C. My lightning strike moment was a series of moments during my time in the military. I deployed to both Iraq and Afghanistan, where I ran ICUs for host national children, and essentially got burned out of clinical medicine. Realized I wanted to stay involved in healthcare, but I didn't think that I had the skills to do anything other than take care of patients. And I actually was debating getting an MBA, or ultimately made the decision to move into consulting. So I spent about 3 years with McKinsey & Company doing strategy consulting for large health systems, insurance companies, and pharmaceutical companies. After a couple of years there, I felt like I had, to be honest, I didn't know the difference between price and cost when I was a practicing physician. I never needed to, and that's okay. But after a little bit of on-the-fly learning with consulting, I moved into the entrepreneurial world. I'm currently the president and co-founder of Orderly Health. We are a data company that basically works to help the interfaces between provider groups and insurance companies manage the data that they pass back and forth, as well as hosting a nationwide provider directory. We're exclusively focused on provider data. And I've been in this for about 5 years, and look forward to sharing my experiences as we go.
Thanks, Ken. I'm just going to go around the horn. Ian, you're up next. Welcome.
Great. Thank you. Thank you, Gustavo. And thanks to all my colleagues who took the time out of their still busy days, not just clinically as we used to be, but also now business-wise. So I appreciate that. My name is Ian Madom. I'm an orthopedic spine surgeon. I still do practice a bit. I spent time in both academic medicine and now in private practice. And I did actually, unlike Kit, go and get an MBA, thinking that that was the way I was going to change my trajectory and get into, hospital administration, be the chief medical officer, run a hospital one day. And then 1 or 2 days before Memorial Day weekend, a number of years back, I had 8 credits of opioid training due within 3 days, 8 hours that I had to get done, and no way of knowing what I should do. And said, why does this problem keep happening to me over and over again? Every few months I'm getting pinged. And had a colleague in business school who is now our co-founder, George Fernane, and we just started building. And it turned into Mocingbird, which is now our company that pairs up the right education for all the different requirements that people have, a variety of certifications, whether it be state licenses or board certifications or other expirables. So excited to share more about my journey and what we're doing to fix our own problems as clinicians.
Thank you so much, Ian. And Navin, when I look at you, I'm looking at a doctor who's also a venture capitalist or leads a venture capital firm. I've never met anyone so I'll just sort of single you out right now. Welcome to the call, but extraordinary. So introduce yourself and your lightning strike moment, if you won't mind.
Yeah, thank you very much. It's a pleasure to be with this crowd here, and I'm going to try to keep it short, I promise. So an anesthesiologist that worked just over a decade in private practice, ended up becoming medical director, and like some of the leadership opportunities, ended up doing some angel investing into companies, got inspired by entrepreneurs, ended up starting my own mobile anesthesia company in 2014 called SmileMD, now known as Offer Health, which essentially enables anesthesia in kids on Medicaid around the country. We're in 5 states, we're venture backed. And that slowly got me the bug of entrepreneurship, and I founded it with 2 other anesthesiologists. A year later, I was meeting all these entrepreneurs. I wasn't considering an MBA, but what I was doing is talking to a bazillion people and trying to learn a lot of the things I did not know. And I started getting comfortable doing it that way. Ended up starting a fund in 2015, a year later, because I met so many entrepreneurs who knew way more than me, but didn't have funding. It wasn't on top of mind, where with us as 3 anesthesiologists starting a company, funding wasn't on top of mind. It was knowledge and how to run a business. So the fund started investing in industry agnostic companies, healthcare and non-healthcare, and that started a whole kind of momentum of investors wanting to get a piece of early stage companies that were moldable. And with regards to deal flow, once you write a check, companies find out and they'll come seek you. But I found a lot of fulfillment. I found a lot of opportunity in the venture space to bring a more holistic approach of helping entrepreneurs, helping them grow. It really takes a lot of empathy to truly be, I think, impactful and successful in this. And I see an opportunity as there's not enough empathy in this space. So what happened was I kept investing. We started building in-house companies. So I'm on my outside of Loud Capital and SmileMD, co-founded a company called Beyond Physician, which is a platform to build your own courses and directly connect to a marketplace. So if there's a physician here that gets something out of this and says, I want to learn more and I want to start doing more to utilize my degree to open up doors, this platform is what we started to build and create. My moment, even though there was a bunch like, Kit said, was feeling empowered that I could do something. And so when that hits you, and that's why I'm on multiple companies, and that's what I like to talk to people about, it's really just opening yourself up, realizing that the rest of the world is not like medicine where you have to be an expert. It's actually the complete opposite. You learn along the way without harming other people, and that's okay.
Yeah, that's super exciting. And by the way, before we get to Christine in just a second, some of you attended a conference recently, right? Ian, I saw you posting some things on LinkedIn. I think Navin as well, Kit as well. So I think that there's a appetite in the industry for what we're all experiencing with all of you on this call right now, to change the industry for the better. Christine, I'm so excited that you're on the call too. You're on the panel as well, because you're taking high tech back to the home, right? You're bringing high tech into the home. So really the floor is yours right now to talk about yourself, your company, and your lightning moment, right?
Yeah, sure. Thanks. Happy to be on such an amazing panel. Thank you guys for the invitation. So I'm Christine Lum Lung. I'm a board certified physician. I've practiced hospital medicine, let's just say for 20 plus years. We'll leave that plus hanging for a long period of time. And for me, this is my second company I've started. It's funny because I never would have called myself an entrepreneur. It was really the genesis of both companies. It got to a point where I was just not able to tolerate the system and the way that it was. So I worked in a hospitalist group in Arizona when I finished residency. Got that if I could create my own hospitalist program, this is what I would do. Someone was silly enough to give me that opportunity. I started a company that I ran and grew here in Colorado, an independent hospital medicine company, when it was increasingly difficult to run independent practices as well. Really loved what I was doing, so it really wasn't that I felt a need to get out and do something different. It was that next step of having really difficult conversations with patients and families, and my only solution to them was to say, I know healthcare sucks, and that was not okay for me. And so I really wanted to go out and build a healthcare system that I wanted to be a part of as a worker, that I wanted my family and my friends to be able to get the care that they needed. And so I basically told my company I'm gonna be leaving in a couple of years and make healthcare better. Didn't really know what that would look like necessarily. Like Ian, I actually went back to get my MBA. Happy to talk about that if people have questions about whether you think that's needed or not. I think a lot of times as physicians, we're told we can't fix healthcare because we don't understand the finances. So in a way, I was doing that to get another tool in my toolkit and maybe a little bit of street cred, and came across a model of care and reading articles about hospital at home, and everything just fell into place for me. And said to some people, like, why not? Why can't we go out there and fix healthcare? We've waited long enough for other people to fix it, and it's clearly not working. And so it's time for us to get in there and fix it. And so I left my company a couple of years ago at the end of beginning of 2021, and we founded Origin Healthcare. And we're basically powering that next generation of healthcare by partnering with organizations to be able to provide patients with hospital care at home. And happy to talk later about what that looks like and where we're doing, but we've been in business almost 2 years. So I think I'm the baby on the team right now as far as startup time, but yeah.
Christine and I had a conversation once, and she said something that I kind of use in conversations now, and it seems to be a theme amongst everybody, is that she said, you know, it's really a problem when the fox is looking over the hen house, right? And you have incumbents in the system that are some of the blockers for really fixing healthcare. And the folks here on this call and other of our colleagues that have plenty of ideas of how to do it really need to just become involved and just start doing stuff and see where it goes, because we're part of the hen house, right? We're the ones that can actually fix the system most effectively, but you just have to start by doing.
Oh,
Yeah,
and Ian, I have another iteration off that. One of my co-founder, this is the other, like, we can't expect hospitals or maybe the current healthcare system to think out of the box, because they are the box, you know. And so I think that's really coming at it from a different lens, but having the experience and the expertise that we all have as clinicians and being so close to the patients and that delivery of care, I think is a really critical part. And too often as clinicians, we're brought solutions and not part of the solution.
Yeah, and you know what, Ian, you just inspired me to go off script a little bit, so forgive me. You know, it's interesting that if buildings have structural issues or problems, seismic, etc., they turn to engineers and architects, right? Healthcare has problems, they turn to legislators and regulators. They don't turn to doctors. And so I just want to put that out there, right? That this industry has looked outside for far too long to solve what's been killing the industry. Secondly, let's talk about medical school. You know, 95% of the folks on the call right now are physicians. So are medical schools thinking in an entrepreneurial way? Are they mentoring? Are they infusing? Are they helping, supporting that entrepreneurial spirit or not? And is that another strategy that's definitely needed in the industry? I just opened that up.
Absolutely. And I think about this all the time, because there is such limited time to train in the physician, you know, in the physician pathway. Although, just like a lot of things, there's a lot of information available now. And so do we need to digest it in the same way that many of us did on this call in medical school? I think school in general, whether you're talking medical school or just school in general, I'm very passionate about education, K through 16, all that stuff. is the leadership skills and all the soft skills that I am using every single day and trying to build, because I never even knew about these skill sets really, or I never applied them outside of medicine. And I focus a lot on that leadership development, personal development. I think we should start that really early. And in that process, you also open up a creative kind of culture and way of saying, I just fell down, let's get up, let's keep figuring it out. And with that approach is very entrepreneurial, which I think could open up the minds on how we can problem solve.
Anyone else want to weigh in on that?
Yeah, I'd love to hear the panel's thought on, so, you know, medical school is where you get your MD. It's not where I learned anything about medicine, though. I feel like I learned 97% of what I know about medicine during residency. And I think that's when you get literally in the belly of the beast. You understand the pain points, you start to see, and maybe it's even in the first couple of years after residency where you're having to be in charge of, you know, you're in a new group or whatnot. But I think we can all agree that, like, introducing the concept of entrepreneurialism, even introducing the concept of financial wherewithal, not just business, but personal. I mean, physicians are set up to come out of their residency making decent money and really haven't ever been trained what to do with it, right? So I think there should be a much more longitudinal series of courses that train folks to both understand personal finances, but also just understand the business of healthcare. And then again, I think going through a residency program, potentially even spending a few years in practice, really does provide you with the understanding, the inside baseball knowledge of how healthcare works.
Yeah, I think the education, some of it's just the way we go into it, and different clinicians see this a different way, right? Starting an undergraduate, if you're going towards the MD-DO route, it is competitive. There is no sense of team, right? There's no sense of collaboration. Maybe you have your small group that you work with. You go through medical school, that intensifies. You're dropped into residency. Okay, you're a team. And okay, you know how to teach now. Wait, we never got these skills. And those are things that are part of that entrepreneurial mindset, right? If you're going to build and fix, like Navin says, you have to be able to go ask questions, right? You have to be able to ask good questions and be humble about what you don't know and be ready to admit what you don't know, right? You don't have to be the expert, but that's not the way we're trained. It's a little bit different, I think, for our colleagues in the nursing fields, that they're trained a little bit different, and you see the way that they lead within organizations as a little bit different because of that. But I think there's a component there in just the style of the education on how we can actually invite people to fix problems through teamwork if we go into just the whole design of how people are educated and even how they're selected for these fields.
And I think some of it too is, depending on, what your lens is. Sometimes we're dealing with the patient in front of us, and that's the most important interaction at that time. But it's also very important to understand how that fits in the larger system. And so you have to be able to narrow in and pull back at the same time. And I think I will say that it's been a while since I've been in med school, but back in the day, we weren't really given that bigger picture. And it's really something on why our group, as a hospitalist group, stayed independent, and our focus as Origin Healthcare being an independent entity is you really have to understand how you fit in the bigger healthcare system, how that decision for an individual patient actually plays out at a bigger scale as well. And to Navin's point, even if it's not being given to you, we need to seek out those understandings. You don't have to be an expert in billing and coding, but you need to understand what it is you did and how that impacts downstream. And I think being able to flex back and forth between the narrow scope and the large is a skill set that hopefully people are understanding is really important to develop.
I'm just curious if we were flies on the wall right now in a residency program, are those leads saying patient sick, heal patient, or should they be saying industry sick, fix industry, right? And that probably isn't even thought about or discussed. Again, right, that's why we're on this call, and that's why this discussion is so important.
Gustavo, I might just add one more thing.
Sure.
I think that we think about the things that we learned in medical school, how to take a history and physical, how to create a differential diagnosis, and we focus exclusively on that as it pertains to patients. But that's exactly what happens in the business world. right? You ask questions, you take a look at what's happening, and then you formulate a hypothesis, and you test it, and you iterate it. And if you realize, oh shit, this isn't the right diagnosis, you have to be able to pivot. And pivot's a word we don't use in medicine, but but we pivot in industry, but we change our diagnosis, or we modify it. So there are a lot of skills that are taught and learned that we just can, it's just a real close connected dot that are actually applicable to the business world writ large.
Oh, great point, Kit. Anyone else on that point? You know, it's fascinating, you know, why are physicians so uniquely positioned to get into healthcare tech to begin with? Thoughts on that?
Yeah, I think the first thing is, I think that there is leadership that there are opportunities, right, throughout your through medical school, through residency, to lead, even in your interactions with working with patients and working with families. As an ortho spine surgeon, right, I spent my early career taking care of some really critically injured people, many of whom had devastating neurologic injuries. And having those conversations that required deep empathy, that required asking questions, and really and leading a family through and a patient through something, I think gives you the opportunity to then lead teams through complex problems, right? Because oftentimes we just had a team offsite, and George, our co-founder, talked about managing chaos in times of, you know, distress. And his ultimate, the way he distilled everything down is there's no chaos. You just have to be able to manage all of these different layers of issues to get to so that everybody's rowing in the same direction. The tech side of it, I don't know if that makes much of a difference, because I didn't know how to build a tech company. I knew how to, you know, see through the physician's lens, at least, the problem that I was trying to solve, and build a product for my colleagues. That really isn't done, right? I walked through that conference you mentioned, Health, out in Las Vegas. There were maybe 5 companies there, and there were hundreds, maybe 5 companies that were actually trying to fix problems for the people delivering care, which is that's just a whole nother issue, right? I think that we as clinicians, as physicians here, are uniquely positioned to be that voice and solve the problems, and stop being just the voice of dissent and complaint and be the voice of solutions.
And I would just add to that most of us, I think almost all of us, go into medicine ultimately to sort of help people. And so that is a fantastic starting point. And so what we've done is transition from helping the one-on-one individual at the bedside to how do we aggregate all of those individuals and create solutions that help all of them. And I think that mindset pervades how we think, and that's a really helpful tool when we get into the business world.
Yeah, I want to just add a few points. So one thing I always revisit with technology as it's touching everything is it's always a good reminder that technology enables people, right? And so whatever is being built is enabling people. And so when we're talking about physicians, I think we are uniquely positioned to really, really not only understand the system that we're in, and so if there's a medical technology or device or product or service, we can figure out what is practically integrated today versus in the future, because we kind of know how the box is. Another thing is we know the patient so well because that was our responsibility. Our duty is to be in charge of the patient, the ultimate decision maker, and being that accountable person. We know the patient very well. We can't miss things. And so when it comes to social determinants, when it comes to all these things, we are really good people that know the data, that know the customer, that know the system, and that is very unique in a company. And so if I'm a teacher and I'm starting an ed tech company, I know my student, but the level that I know my student in and around, like we know patients, is different. And so that's really a rich source of acceleration of time and knowledge for a company. So what I like to say is physicians should definitely be at the table with incorporating the other level of talent, but physicians should be really, really at one of the driver's seats because of all that information that is so crucial that people would love to extract from our brain. And the other problem is physicians don't really understand what I just said in the sense of having that confidence that they know so much, but they do. Very, very rich in knowledge and experience, and then ethics. All that combined, this is gold.
Yeah,
I will say just one other piece of that. It just jogged my thoughts of, and like all of that to me is summarized by passion, right? Like we are passionate about taking care of people. The amount of times that I know myself and my colleagues spend on phone calls with insurance companies denying care, right? It's not just, you're not just going through an exercise. You feel this sense, you feel this fire because you're like, no, you're affecting my ability to care for this person, and I know that this is right. That's a sense that can really drive change and effective change in a system. I'm in the midst of having a conversation with my wife who has never done anything entrepreneurial, and she's an OBGYN. She's passionate about maternal care, and I'm like, you got to do something. Like you have that passion. That's going to drive something further than somebody who just identifies a problem from outside of healthcare. Oh, I can go fix that. I can add this business model. I mean, sure, that might work, but to me, that's not mission driven. That's not something that really will have sustaining power to get everybody on board and really effectively change healthcare.
Yeah, I mean, how many CEOs of hospital systems or even tech companies have been at the bedside during those really challenging moments? And to your point, Ian, they don't see the pain, they feel it, right? And I think that drives that passion and that motivation to fix things.
And the last thing I would say, I think all these comments are so awesome, is that we're really at that intersection, right? We have like very direct accountability to our patients, but also to our clinical colleagues, nurses, physicians, everybody else in this, the administration, the bigger system. I mean, we're kind of that collective point where everything comes back to, and we're already innovating and coming up with novel solutions, just not knowing that's what we're doing, right? When we have a patient who doesn't have insurance, but yet I have to get out of the hospital with medications, monitoring on Coumadin, like we are figuring that out every day. We've not just come in at the frame of the fact that we're doing that. And now we're finding voice in the ability to say, you know, we're actually going to make this a bigger statement about what we're doing, maybe be more effective, start reaching out to other physicians who are doing the same thing and try to create more of a momentum to making this more the norm rather than this being, it's so unusual that we have to have a panel about it actually, right? And, you know, 5 years, hopefully everyone will be like, of course, physicians are leading change in healthcare, so.
Yeah, that's a great point. I'm just curious, do you all think that healthcare is too big to pivot, to change, to evolve? Or is it going to have to be this sort of like what we're experiencing right now in real time? A group of 5, a group of 25, a group of 205 individuals like yourselves who change different verticals within the industry, right? At-home care, you know, credentialing, licensure, documentation, all those issues. Do you think how's this going to work? Because remember, I'm kind of dating myself a little bit. Hillary Clinton, Jackson Hole, we all remember that, right? Healthcare reform led to the Affordable Care Act, which was transformational, historic, and has saved countless lives, right? And expanded care to millions of people. But I'm wondering, is the industry just too big to truly change? Or is it going to have to be, again, sort of a piecemeal approach? Thoughts on that?
So I think if we start to think that it's too big to change, none of us would do anything. We'd be too worried. I go back to what's that adage that if you're a ship coming out of, you know, port, and you change it just by 1 degree, you'll end up in Alaska or Australia, whatever that saying is. And so our company approaches it like, if we can just change healthcare 1 degree down the road here, it's going to make such a big impact. And so we want to make sure that people don't think it's too big to be changed, so that they don't hesitate to get up and try to do this. I think the one caution is that sometimes I see, so I remember when Haven launched, you know, there was so much, you know, they can't possibly fix all of healthcare. And it's the understanding of like, no one company is trying to fix all of healthcare. I mean, if any of us go and think we're trying to fix every problem, then yeah, we'll be set up to fail. So also coming at to a realistic standpoint of, what is it, the solution we're trying to fix, and understanding that that solution is out there and it is fixable. I think also the other thing I would say is we also want to be mindful of what we also see in the hospital sometimes is by fixing one thing that we don't create a problem in another area too, and being super mindful of if I want to improve length of stay, or if I want to improve discharge by noon, I think we've all heard that one, discharge by noon, I can solve that. I'll just keep people one more day and I'll discharge them at 9 a.m. And so it's understanding that if you're looking at, one metric or one measure of success, that might not be fair to what it is that you're doing.
Good.
Yeah, I would say that I to keep with the seafaring theme of of that Christine just laid out, I don't like the idea of boiling the ocean, right? And I really feel if you are going to change, you can't disrupt healthcare. It is too big to disrupt healthcare, but you can innovate on the edges. You can innovate on the edges and continue to iterate over time that people, and in a way, even our own colleagues don't want their workflow changed dramatically because it's uncomfortable. It doesn't, it creates too much disruption in the rest of their life or in their thought process or in their ability to actually care for people efficiently, that's too tough. So if we offer solutions that can innovate a little bit at a time, just on the edges, and slowly move in a direction, it's that similar concept of just changing 1 degree.
Yeah, I completely agree with that. And I think I would also agree that it is such a behemoth that it is hard to change all at once. But I will say I've seen over the course of the last 10 years, and even it's accelerated over the last 2 years, the consumerization of healthcare, the consumerization of access to data. I think we're starting to see sort of a groundswell among the population that says, I'm actually not going to take this anymore. Like, and the more folks that come together and say, I'm actually going to choose this small thing that's doing a better job than going with this bigger option. And we're seeing that with startup insurance companies. We're seeing it with at-home care. I mean, there's a lot of these things that are happening that are really starting to make a difference. One thing that I'll say that is not a great trend that is happening is these things, there's a lot of innovation happening by these smaller companies that then get swallowed up by these behemoths and thrown out for, and just disposed of. And so that's a problem that we still haven't quite figured out. I've known a lot of companies that have been kind of subsumed by a larger company and then basically kind of disassembled for parts, and it loses all of its mojo. And so we just need to be careful of that and think about how we approach it kind of going forward.
Yeah, I'll just add my 2 cents, which might be a little different perspective. And so when I'm talking, I'm speaking definitely on the outside. I talk to a lot of payers in different states. So insurance companies, that's obviously money and influence. I talk to governments, state, and now some federal conversations. And obviously a lot of investors, private funds, banks, et cetera, and what they're investing in. So the bad news is there's no choice to really radically change because the systems, as we know, have been stress tested and they've failed and they're continuing to fail. And when I say fail, I mean the hospital system that I left end of 2019, full ORs, 30 ORs, cannot even staff it now because there's enough business, because they don't have enough staff and they don't have enough this and that. It's a domino effect. So many people are leaving. And this is I'm in Columbus, Ohio, a pretty good sized city with a great hospital system. They can't keep that filled. That's obviously one of many systems that are happening. So what's happening? The longer line of patients who need help. And obviously during the pandemic, we got adoption of telemedicine on a large scale. Even though telemedicine was there before, it took a whack in the face to say, let's open this channel up. So payers are now paying that, and that's part of our healthcare economy, let's call it. But now what's happening is, since we're reaching in the home, we're reaching in offices, we're reaching in, let's call it last mile, the payers and investors and everyone else is much more open to this new, wall that just got thrown down of like, wait, this is cheaper, this is quicker, this reaches the patient closer. And then all these providers meaning anyone from nurses, paramedics, physicians, all these people I have the privilege to talk to a lot of are reaching out saying, how can I just left my hospital system, how can I get plugged in this last mile service? So I know I said a lot, but I actually think the change has already started. It's accelerating. The money, the people, and now tech and entrepreneurs are all going that way. So it's happening. The question is what it looks like. But that to me is reassuring. And one thing I stress about are the calls of physicians I get from all around who are burned out, don't want to tolerate anymore, still care about the patients and are trying to find that clinical career or vehicle to take care of patients. That's not built yet for everyone, but I can tell you right now, I'm personally working on it along with a lot of other people. When that's ready, we're going to have a lot of great people taking care of patients again in a different system that might not be very central, but supported by a lot of the same people that supported the big box.
Yeah, I would say that it's a lot of early adopters right now, right? Like that's definitely where we're at. It's how do we jump that chasm with folks that, you know, our colleagues are conservative. Like we're trained to be conservative, right? We're trained to think of horses, not zebras, when we hear hoofbeats. And I think that's some of the challenge as well. And like, while adoption of telemedicine, right? This is specific to Mockingbird, that we a challenge that we face is, you know, adoption of telemedicine. Yeah, we're seeing it go through the roof, but we're not seeing adoption of helping those folks to actually manage all of the work that they need to do to deliver those services. Like you have 10 different licenses and there's still the same attitude. That's the doctor's problem, right? That has to change along with the system. Like the attitudes, the system can't just change by itself. The attitudes have to change too, because you can't apply those old attitudes to a modern system. It won't succeed.
Yeah, and just to clarify something, I don't know if it's a show of hands or just your comments, but it's a little bit counterintuitive because, you know, this conversation is about being entrepreneurial. This conversation is about bringing change, thinking about change, and having the physicians who are right now witnessing all of this think about how they can impact healthcare, how can they can improve healthcare. Does that mean they have to leave the profession? So Ian, you said you're still practicing and you're running a company, right? To a certain degree. To a certain degree.
My wife doesn't love it because I'm trying to do 2 full-time jobs.
Are you in the basement right now, by the way? Are you in the basement?
So that's definitely a challenge. I mean, I personally feel that I don't want to totally leave because I feel it gives me some credibility. It keeps me close to what the problems are. Right. I know that Mockingbird isn't the last thing. I hope to be like everybody else here who has done it a couple times and solve some other problems. And I want to stay in it. I still really enjoy delivering care, but I just do it on a far smaller scale than I used to do. So I don't think you have to, but it's definitely not for the faint of heart to do both. I have a colleague who is the president of a large hospital organization in Western Connecticut, and it bleeds over into New York. He's an ER doc, and he doesn't do a lot, but he still sees patients in the ER 1 or 2 shifts a month. Another one is a CEO. I think he just took over as CEO of the University of Vermont system. And when I talked to him, are you gonna still do anesthesia? He's like, I don't know if I can do it anymore as the CEO of a large hospital system, but I know he wants to. And I feel like there are people that still want to if given the right opportunity.
Yeah, good. Christine and Navin, what are your thoughts?
Yeah, I think this is another exercise I think about all the time because I don't want people to leave medicine. Like I'm a little bit of a radical aspect, but most people want to keep a clinical component. In a perfect world, the future physician to me looks like, I'm just throwing this out, about 60% clinical, about 10 to 20% admin, as in duties within the box or the structure of healthcare. And the other 20%, which is what I feel very strongly about, is to sit on boards in healthcare and non-healthcare and sit in companies in non-healthcare to help influence the focus on people and the ethics of health. Because health is not just healthcare, health is preventative, mental health, all these things of keeping people in mind. Just like tech companies have chief ethical officers, right? That's an interesting concept, and tech companies have totally taken that on. I really think there should be physicians in leadership positions outside of healthcare, of course within healthcare, so that what that does for us as leaders and intelligent people, incredible people, is it helps us learn and contribute to a lot of things and influence in a positive manner. It keeps us fulfilled, and I think it keeps the creative juices going. So in a perfect world, if I had had that, I'm not sure I would be here and done the radical moves. I have no regrets, but I really think about the future, because we can't have people leave to problem solve. We should be problem solving on the job while treating patients. We can do it all.
And I still practice. Part of that is just the realistic part of being a startup, and we have a clinically focused startup. You are chief cook and bottle washer, so some of that's, but I think, there's no one size fits all, and I would hesitate to say that there should be an absolute for everybody. I think it's a very individual decision. I would say just be mindful when you're going into a startup. So part of the CME part of this is talking about burnout. My caution is, do not go start a company if you're thinking it'll be easier than the job you already have. It is not easier. It is a whole nother level of pain that you will wonder what you did at certain times. So all that being said is that you need to do stuff that brings you fulfillment while you're doing that, right? And in the very hard part of starting up a company with the incumbents that we talked about, and some really disappointing and challenging conversations that I've had with people in healthcare over this last couple of years, I'll see a patient and the gratitude, the thanks, their family, the relief. I'm like, okay, yep, that's why I do it. My cup sort of anger sort of drains again, and I can go back out and do it again. And so it's really whatever works for you, whatever works for your family. I don't think, again, there's anything absolute. I think, to Navin's point, the workforce issue, but part of what we're doing, hopefully, is we're creating, as he said, an opportunity to keep people in the field in a way that provides and gives them meaning. And I think we're going to see that come in all shapes and forms.
And I've taken a slightly different tack. So my personal choice was to get out of clinical medicine completely, but I have maintained my licensing and board certification, although I'll tell you the board questions are getting harder and harder the further out of clinical medicine I've been. But I do that because I also volunteer. I make it a point every year, 1 to 2 weeks, I take off and I go volunteer in a clinical capacity. It's not, I won't get into what I do, but like I make an intentional decision to have that sort of bedside time to, like Christine said, sort of recharge my cup. And in addition, I also, volunteer with, there's orderly health is not pediatric focused, and that my training is in pediatrics. So I have some knowledge to give. And I for example, I'm a mentor at the Kids X Health Accelerator of UCLA to help young startups that need some medical advice. So there are other ways to get that fulfillment that I think is uniquely available only in clinical medicine, but there are other ways to kind of get surrogate feelings that way. So that's kind of how I've approached it.
Yeah, it's part of our identity, right? For better or for worse. And we really spend so much time doing it through the training process in medical school. You can't really divorce that. It's almost ignoring it, a part of you, and something bad might happen to you if you ignore that part of you. And I love Navin's idea that can really foster this this ecosystem to change, first maybe in healthcare, but then outside, that we think about health. A lot of people say this, right? Like, we have a sick care system, not a healthcare system. Well, health and wellness having the people who deliver that sit on all, it would be interesting, the chief health officer as part of Pepsi, if Indra Nooyi maybe wanted to get back get back in play, she could get something going on like that. But I love the concept, and I love thinking about the future as us being integral outside of just healthcare.
And one thing I'll just add is I think that we can talk about entrepreneurialism in a way that doesn't mean leaving medicine and doing something entirely different. Entrepreneurialism can be saying, I see a problem with this small thing in my department, and coming up with a solution for that will actually make my life better, make the patients' lives better. So don't think that you have to be an entrepreneur, you have to quit your day job and start a company. That, in my opinion, that is not what it means. It just means thinking about things from a new perspective, coming up with a solution and trying to implement it. So start small. You know, there's also every day you're coming across things that you see, processes that you're forced to be a part of that can be made better with simple tweaks.
I agree with that. I just want to add another opportunity I get is to talk to a lot of medical students, and they reach out because they're excited about entrepreneurship and startups. And they have that desire to, hey, I want to be an orthopedic surgeon, but I also know I want to do these things. And so that's kind of how I also frame that, as like, you can do all of that. And to your point, Kit, it's not like you have to have your own startup. In fact, if you look at leaders in other industries and organizations, they do sit on boards in different areas. It's not as common for the physician, maybe because we're really busy. Again, I also think where the world is just so isolated in the healthcare world, and we also think that we need to be this expert to even look left or right. I mean, I have those conversations every day on trying to break down those barriers on, you're a smart, intelligent person who takes care of a person's life. You can do a lot more than you think. So it's really just exposing that. And that's kind of what I'm passionate about, is just opening our minds and our community and giving a little bit of empowerment. And that can really change how we feel about ourselves and our impact distance.
Yeah, a lot of people will say, when, you know, faced with some challenges, they'll be like, but, you know, there's so many blockers within healthcare. Like, there's people who don't want to do things. They say, welcome to startup. Like, that's, you're going to do the same, you're going to face the same challenges outside. They're just going to be different people blocking you and different people telling you that won't work. And, you know, whether you're doing it from intrapreneurship or entrepreneurship, I think it would benefit all of us sitting here, and all of our colleagues, to have more people jump in the fray.
Yeah, thanks for that, Ian. Hey, we got our first chat question as we hit the 48-minute mark. We've got about 10 minutes left, so we got a question at 2:17 our time. Why are physicians not politically positioned to affect healthcare delivery solutions? And thanks for the question, or the physician who posed the question. Anyone? I'll ask the question again. Why are physicians not politically positioned to affect healthcare delivery solutions?
I mean, I'll say, I think some are, right? I think that there are PACs that are out there with certain organizations, North American Spine Society and the American Academy of Orthopedic Surgeons certainly do a great job of this, of meeting with people on Capitol Hill, meeting with local politicians and having conversations and educating people. But you really have to take it from the stance of, like, I don't want to feel like a lobbyist. I want to feel like somebody who's educating, somebody who's making legislation on what the real life effects are at the bedside. So
I'm not sure if I fully understand the question, but I do think there are a lot of political opportunities. There's surgeon generals at sort of every level of the spectrum. I think what we've seen, though, is once they get inside of the political system, they get handcuffed, and they actually can't really make a lot of change. They're sort of forced to play by the rules, so they can't think outside of the rules. So I mean, I do think there are certainly political appointees, and we can name a lot of them, but I think that we run into the problem of once you're inside the system, you just become a part of the problem and don't have the agency to really make those drastic changes.
I would say if we have limited time and money and limited people, right? Because physicians are a smaller group compared to some other groups. I see a lot of whatever focus is happening on the current system, the box we call it, and let's say people are fighting for reimbursement because they're about to get cut. So they're already in a defensive position, and they're already positioning it in a very high cost center with so many layers. And so once again, I'm a little bit reassured, because when I'm talking to the payers, they're now embracing these other models where the payer is spending less, but the pool is so much thinner, and the physicians have an opportunity to let's say earn more if we're just talking about reimbursements. So what I tell people is, don't, even though it's hard, you know, you're a practicing surgeon and you're, you know, thinking about reimbursements, I understand that, but this is a slow and big system politically, etc. And so if you can think a little bit ahead, it's really about where the money and model's going, and ensuring that physicians have a larger presence, and we don't have as much layers of of where all the cost goes. So that's kind of how I feel about it. And it's just being more focused and aligned versus, hey, I'm in this silo, my field's getting hit. We need to start thinking a little bit more pro physician in general, but I know it's easier said than done. I just wanted to share that.
Yep. Christine?
I think the other part, two parts about that. I think the reactive versus being proactive, huge point. When you're putting out fires every day, sometimes it's hard to look ahead. And you know, that comes from the physician level, as well as there's been health systems that I've met with this year who have basically said, we're too busy to innovate, you know, and is that actually an appropriate mindset to be thinking about this, that we don't have the time to be thinking 2 steps ahead? I think the other question really that's out there, and I don't have a great answer for it, is like, whose responsibility is it? You know, we say it's the government's responsibility. It comes down to CMS. The private payers tend to, quote, follow CMS's lead. Like, is that appropriate? And I think we're starting to see the cracks in that right now, and that the Amazons, the Walmarts, the Best Buy, you're having retail come in and saying, we're sort of not a part of that whole, you know, foundation that sort of says that's the way this has to go and the decisions have to come here before they fix. And so they're in there and they're going to create, you know, change whether people like it or not. And so I think, you know, that's opening up our eyes to the different possibilities, and these other partners who have said in the past, where we have to wait for X to be the one to provide us the payment mechanism in order to do this. I mean, don't get me wrong, the payment model is not a small thing to be putting to the side. So I get that piece, but it's really, you know, who are we waiting on to do this, and what other things can we be moving forward with? And
it's, you know, it's not easy to be engaged, right? Because as you just said, Christine, like, you know, you spend your day at the bedside and you're exhausted at the end of the day. You're going to a dinner meeting, right, to meet somebody. You're going to, you know, to educate people or exert any kind of influence. That takes time, and that's time away from your family. That's time away from the workout that you didn't get up at 4:30 in the morning to do. These are other parts of you that still need to be nourished, right, as a human being, and finding that balance is challenging. Not doing anything, I don't think, is the right answer. But it has to be done within reason. If we have more people engaged, it makes it a whole lot easier to get these things done, because it doesn't take just 10 people, it takes thousands.
I appreciate that, Ian. And this is a perfect segue into my plug for the LA County Medical Association, because you would think that's why we're here. Well, that's why we are here. I mean, my association, our association, I've got a couple staffers on the call right now. I call us a 151-year-old startup, because that's what we are. We've been around since 1871. And this model of a medical association was just not sustainable when I took it over almost 7 years ago, for a different day, for a different discussion. But I want to put that out there. The next question, we've only got about 6 minutes left, you know, and I almost want to answer this myself. Why are doctors not at the table but on the menu? Well, if I could just throw out very quickly, because I spent 25 years in the hospital business, I never met a hospital or health system physician CEO. It was always chief medical officer, chief quality officer, chief of staff, right? But all the CEOs, no offense to the MBAs on the call, because we're all, you know, everyone's an MBA, but you know where I'm going, right? None of the hospitals I worked at, and I'm from San Diego, had a physician executive. So all the decisions, the planning, infrastructure, all of that was done by a true administrator without being a physician. So I want to put that out there as part of the reason why sometimes physicians are on the menu and not at the table. But that's the question. What are your thoughts on that? Why are doctors not at the table but on the menu?
I think it's starting to change. I think it's starting to change. I actually, you know, I mentioned it before, you know, a colleague of mine, Sonny Eapen, just became the head of the University of Vermont. Their whole, you know, medical system, 8 hospitals. I think that people are starting to eye those opportunities and take those challenges on. Part of it has been some of this imposter syndrome stuff that Navin has spoken about, right? Like, are we good enough? Do we have the knowledge base? You know how to ask questions. You know how to learn quickly. You know how to learn on the fly. And you know how to balance risk and understand trade-offs, right? Like, those are the things that are needed in the new healthcare system. So I love the idea. I still, I said, oh, I left that trajectory of going. I still see myself maybe doing that someday, because I think that it would be helpful. But I do see that people are taking those opportunities and those are being afforded to them.
Yeah, I agree. I think, usually you have the pathways of obstacles. And so there's obstacles to these tables, but in our case, I think the community is not empowered enough. And so if I had to, me personally, put my focus, that's what I really like to do, is number one, give some confidence and empowerment, and then the hunger. Do you know that there's a lot of administrators who only just have a business degree but don't really have any other healthcare experience, and they're running the hospital system that you're employed by? You start giving some hunger and start giving some pathways to say, this is how you can arm yourself, get some confidence and move forward. Then you have an army of a physician community who wants to do things, will make it happen. Like, we can do whatever we want, but we have to want it and be confident that we can do it. And that right there is the missing piece, in my opinion, which is really unique for such a smart and accomplished community. But here we are, it's all good. So.
Yeah, and I would agree with Ian. I think it is changing. I think for the longest time, physicians weren't aware that there was a table or a menu. Like, we didn't know that either of those things existed, right? So I think we're now aware of it, and I'm seeing a pretty significant. I mean, it is changing, and so now that we know, that we're on the menu, we're starting to get behind the scenes and help print it. So I think that change is afoot, and it's a good thing.
And I think the last thing that I would say is, while it is changing, is don't let that hold you back from doing what Kit was saying. You don't have to have a title. You don't have to be the CEO. You don't have to be administrator to impact and make change happen. And so don't let that be a barrier to you. We all have choices on whether we fix that problem in front of us, whether we wait for someone else, whether we throw up our hands and just, say we're giving up at this point. So empowering anybody who's on the call right now is, seek out those opportunities, but also create your own.
Thanks for that, Christine. We've got about 2 minutes left. So I want to, for those who put something in the suggestion or the question area, we'll make sure that we respond to you appropriately in a timely way too. But one of the questions that was sent was, why are doctors called providers rather than physicians? Well, let's spend about 60 seconds on that one before we close out. So why are doctors called providers rather than physicians?
I actually want to chime in on this because I feel like I've recently explained at a leadership meeting why that is from a functional perspective. And so there was non-healthcare leadership in a meeting talking about it, and they were asking me, and I was explaining that a physician is a physician. Providers usually are a category for a lot of other folks, and then physicians feel very strongly about it, especially people around me who've let me know. I personally am a little bit more neutral, and I think people get mad at me when I say that, but I'm just saying. But on the other side, it's a functional thing. So if I'm a exec of a hospital that's not a physician, and I say I need people and staff, providers has been used to categorize that group. That's why I think there's a comfort there. That's just a quick perspective. And when I explain that to some of these non-healthcare folks, they understood on the physician side. I just wanted to share that because I recently talked about that.
I will say quickly that I've had this conversation with a number of my Jewish colleagues who there is actually some ties back to the Holocaust about it, and that it's a pretty negative term. We at Mockingbird, I mean, I've kind of embraced clinician because I'm clinical staff, right? I'm a physician, but I'm a clinician, right? And people who provide clinical care, I think it's more encompassing. Jen Weiss, who's out, she's one of your members in LA. She's an orthopedic surgeon out there. She kind of encouraged me over a conversation a couple of years ago, and I started to do some reading on it. And I think it's a more friendly term, but that needle's always moving too.
Huh. That's news to me, by the way. So I appreciate that, Ian.
Okay, Christine. Okay.
I'm not dipping my toes into this water, that's for sure.
Christine,
And
you have a
time.
final word before we close out, Christine. Anything?
Oh, final word, not about this though, right?
Okay.
I don't want to
Okay.
end on this. I think we need to end on a high note.
Yeah,
Let's end on a
I
rally cry.
agree.
End with a rally cry, Gustavo.
Okay. We're at 2:30 Pacific time, but that means that we have 60 more seconds within the 2:30 time frame. So any parting comments? You have 30 seconds to just give some parting comments.
Also, really quick, I think any of us would say, please reach out to us. I am not the expert in this area, but I am always happy to share with anyone my experiences, my ideas. I think I mentioned this at a recent conference. I don't think we are taught to network as well as other areas and industries are. And so consider you all part of my network and feel free to reach out to me at any time with questions.
Thanks, Christine. Kit?
Yeah.
That's exactly what I was going to say. I was going to say the networking piece. I don't think we do a very good job of that as physicians. I think we have too much humility sometimes and don't want to ask for help, but we all need help. And networking is just how the world works. And if you don't get on board with it, you're going to be left behind.
Yeah, thank you. Ian?
I just want to say thank you to everybody who joined. Thank you, Gustavo, for leading a great conversation, and Christine, Navin, and Kit. This was awesome.
Great. And Navin, you have the final word.
Yeah, just like Christine said, there's a lot we can do, and when it comes to networking, I'm on LinkedIn. I post every single day something positive and something empowering, and it has nothing to do with just being a physician, because we are a very complete human being, and if we can have a little bit more confidence to do what we really want to do that's in our brain, we can do anything we want. That literally is what we can do. We tell our kids that, we should tell ourselves that.
Follow Navin. He's my guru. He definitely keeps it positive some days.
I want to thank all of you, and I want to thank the folks that were on the call as well. As Christine said, we all have now developed a new network within another network. So let's all stay together. Let's make this a regular conversation versus a one-off, right? So love to continue the conversation. Kit, you mentioned UCLA. We do a lot of work with UCLA. I want to talk to you about that too. But I want to really thank Mockingbird, Orderly, and I want to thank PC Med for really making this happen from a technical perspective. Round of applause for them. And thank the audience. And again, if anyone has any questions, there's contact information available to you. Katie's been sending it out. And again, I want to thank everyone, the panelists, the audience, and really have a wonderful and safe afternoon. So thank you again, everybody. Thank you.